Our next speaker, I'm very delighted to introduce, is Dr. Tom Kelly, who's a pediatric endocrinologist here in San Diego at Rady Children's Hospital. I was trying to think, is this your third conference now with us, I believe? Second, okay. Well, it feels like you're a big part of this group now. So I think this time Dr. Kelly has actually really tailored his talk to issues with Jacobsen syndrome. So again, I stand to learn a lot of about this as you do. So we're really excited and thrilled to have you. We have a few things for you, a 11Q t-shirt, gift certificate, and a bottle of wine from the Sulpizio family's private vineyard, kindly donated. So thank you, and we're very happy to have you here.
Thank you very much. I'm always flattered. You know, I had such a great experience here last time. It really, I did my talk also in the morning last time, and I had clinic in the afternoon. One of the luxuries about being able to speak in a place where you live. So it was, and it really motivated me, you know, during that whole time. And it really, it's like sometimes those visits can really, with a patient in clinic, can really push us along, or an event in a hospital can really motivate us, and that conference really kind of pushed me for a bit. You know, when we give a talk, it's always, you know, one of the things we don't usually like to do is follow a great speaker, a great talk, and so I was thank you for the break. That always kind of divides things up a little bit there. You know, sometimes they'll say, well, maybe if you tell a joke in the beginning, it might make things a little bit too. So, so I have one. So there was a cop pulled over a guy, and he's driving down Interstate 5, and he looks over and he sees some penguins in the back, and the guy says, hey, you know, why'd you pull me over? I wasn't speeding. And he said, you have penguins in the back of your car. He says, okay. And he says, well, those penguins, they need to go to SeaWorld. I'm trying to make this local with San Diego. So take these penguins to SeaWorld now. And he said, okay, okay. So the next day, same cop sees the guy, penguins in the back. Hey, I thought I told you to take these penguins to SeaWorld. He goes, we did. We had so much fun. Today we're going to the zoo. So it's nice that we do have this conference also in San Diego for other reasons, for you guys to be able to enjoy. I know a lot of people traveling from far places. And so for that reason, I wanted to give you guys, and start off just with some contact information. So having a name, Tom Kelly, is so utterly rare that it's so difficult to actually have an email just with your name. So it's T1Kelly at ucsd.edu, and it's Kelly with K-E-L-L-Y. T1Kelly at ucsd.edu. There's T. Kelly at rchsd.edu, Thomas G. Kelly MD at gmail.edu, or so there's I have a few, but whichever way, if you wanted to do that. Also, I kind of have a bad reputation of handing out my cell phone number to a lot of families, and that's probably because a lot of families, I have children, I also take care of children with diabetes, and a lot of times they just kind of want to just get someone on the phone right away. We also have them, of course, page. But if you wanted to, it's 858-123-4567. No, so 858-740-7137. And I'm fine with that. So with that, if it, of course, just says, you know, with anything, if it's an emergency, I would, you know, recommend you
hang up your phone and call.
Yeah, 911 and all that. Okay, so with this, it's what I really wanted to focus on is giving you guys a bit of a toolkit, something to work with, something that's tangible, because we know as parents, a lot of times we are advocates for our children, and a lot of times we kind of have to just guide the visits, the clinic visits, or at least feel a little bit prepared, and what kind of questions should we ask. Now fortunately, and with a lot of the things that we're going to be talking about with endocrinology, which is with hormones, a lot of these things that we're going to be addressing or looking at today are things that a pediatric endocrinologist should really be looking for and considering with a lot of these things. However, they may not be familiar with Jacobsen syndrome, and so it may be kind of nice to be able to kind of say, hey, also, but we have, and this happens, so that we can kind of guide things along and so the right things are done. So just starting off, I mean, approximately 25% of children with Jacobsen syndrome plot at the 25th percentile. So when you're looking at a growth curve, which we'll review today, but as many as 75%, 3/4, are below the 10th percentile. Okay, but what does that really mean? We'll go over that today in terms of, is that where they should be for the family or not? And there's ways that you can assess that, which we'll review today. About 50% of these are considered to have short stature. Okay, and what we define as short stature. And then growth velocity may also be decreased. So it may not only be plotting lower on a growth curve, but then also maybe be falling farther off a growth curve and the implications of that. So starting off usually with a lot of things, you start off with definitions. And so basically if we're looking at height or height percentiles, these are with the growth charts that we look at. And periodically we will change these, and so the more current growth charts that we're using is growth charts here in the United States for the Centers of Disease Control, and I specify that because I know we have people listening and tuning in from Australia. But also some people do ask if there are specific ethnic-based growth charts, and there are, and you can get those online from different parts of the world, or different ethnic groups from different parts of the world, and just right on the online. Also, growth charts in younger kids, we're finding that we're using the World Health Organization charts. It tends to be a little bit more reliable for those kids. So that's the WHO charts. Growth velocity, basically how fast that child is growing. Mid-parental height is a calculation, it's a formula, kind of a crude formula, basically what height should your child be, basically based on your parents, okay? So if we had two parents that were 20 feet tall, of course the child's going to be expected to be taller. If both parents were about 2 feet tall, much smaller, okay, obviously in extremes. Bone age is something which we'll go through a little bit also, and that's an assessment of how much time we have left to grow. So if you think about things in this way, is that if you are plotting on a growth chart and you're growing at a certain rate and you need to get to a certain height, as long as you're growing at a normal rate, you're going to be predicted to be typically at that same percentile later on once you finish growing. But things can influence that. If you're not growing very well, such as if you had growth hormone deficiency, thyroid hormone deficiency, or for some other reasons, which we'll talk about today, then you're not going to be growing as well and perhaps falling farther off the growth chart. If you have less time or more time to grow, that's going to influence things too. So if you have additional growth in your bones, which we'll be able to see today how that's relevant, then you may actually be one of those people that grow after other people finish growing. And we know some of those people that we might have grown up with that just grew after high school. You know, you go to a reunion, you're like, whoa, what happened to that person? There can be quite a significant amount of increase in growth left over with it. I can't really confirm this, but supposedly Shaquille O'Neal was one of those people, so much smaller than everyone else when he was in high school. So when we're really looking at assessing growth, we're looking at height, growth velocity, and their predicted height, as we said. And the height, we really want to make sure that we're very precise. And this is an example of the CDC charts that we're using. And what gets a little bit now confusing is as a lot of the hospitals and clinics are using electronic medical records, we're not typically seeing this growth chart anymore. We're seeing other variations of that. The data also with these electronic growth charts should correlate or correspond to these, but as we've even seen here locally, that it doesn't necessarily always meet our expectations. And so sometimes just getting out a pencil and a paper and growth chart and really plotting things out, but really keeping track and making sure of how accurate we are. So what creates errors in measurement? We often, from a pediatric endocrinologist, get referrals for patients that really were plotted incorrectly. They were plotted based on their birth weight. That would be also another problem for height too, but if they're plotted on their birthdays, so say if they're 8 years old, but they're going to be 9 tomorrow, and they're like, oh, you're 8. You know, the other would be sometimes standing with the scales that are on, or the measurements that are on a scale, the floppy arm, having to move the kid off in order to get the height and see where they're at. So if you're suspecting that the growth is not really being monitored closely, then really just make sure that you have someone that really is reliable with that. And it may be just having someone that's specifically trained in that office, that pediatrician's office, maybe the pediatrician themselves, or just really just making sure that it's done correctly. energetically. Another thing is that some things that can affect growth is if there's scoliosis. Now, there can be some bone or bone-related problems with Jacobsen syndrome, and scoliosis can happen. Also, too, is that something I stress with all my families is that I think sometimes we get so wrapped up in a particular disease or condition or syndrome, we forget that, these guys and girls, they can be normal and have normal other things. They can get things that other kids can get to, and scoliosis can be one of them. So if you have someone that their spine is curved, they're going to be smaller in stature. And that's something that we would consider not only with assessing, but also then with treatment too, to see really making sure that we're not going to do any harm and causing any type of further curvature of that spine. Most evidence right now with growth hormone doesn't necessarily, the data doesn't implicate growth hormone as worsening scoliosis, but in some sort of bone conditions it perhaps can. So we have to be very cognizant of that. The other is, and how fast are you growing? If you're falling farther off the growth curve, we want to be able to act on this in order to really catch up. And when we're looking at any drop or increase or decrease along that line, so these different lines that we see on a growth curve are percentiles. So if somebody's on the 50th percentile, means 50% of the population is either their height or above them in height, and 50% are below. If you have someone that's at the 10th percentile, about 90% of children, their age or their height or above, or 10% or their height or below. But typically, kids will follow right along their lines, and if you have someone that's falling below or increasing, then you'll see that that does make a difference. Timing of puberty plays a significant role with this. Cryptorchidism, as we'll go over today, which is undescended testes, can be associated with hypogonadism, and we do see that as an increased, or is the prevalence of that, or what we see, the amount of children we see with that with Jacobsen syndrome is significant. And so if we're looking at someone that may not be producing these sex hormones or pubertal hormones, what we'll call them, then they may be delayed in going into puberty, maybe not starting into puberty. And we're going to see that as a reflection on the bone age, which we'll see. But we're also going to see that on perhaps growth, because the growth rate is going to be increased during puberty. And you can see that, so if we look at what's normal, during puberty, kids are going to be growing much more rapidly. If someone is not going into puberty, they're not going to be growing as rapidly. And just before the onset of puberty, you can also see a decrease in growth velocity. And this is something that if you take a look at these growth curves carefully, you can see at the bottom of just around the time of, let me see if I, right in this area here, do you see how it kind of buckles down or dips there? That's around the time of onset of puberty, and it's a little bit more pronounced in boys than in girls, but normally kids do decrease their growth velocity and then they start picking back up again. So this is also a time when if somebody was plotting on the lower end of the growth curve and then right around the time of going into puberty, then it's often the families will say, you know what, we've been always kind of growing a little bit more slowly than other people, plotting farther below, but then now more recently I don't think he's grown at all, during this time. And that's often what we're seeing right around that time. We do a pubertal assessment and we find out that we're right around that time. And so that in some ways can be reassuring, but then of course we have to put everything in perspective, and especially with Jacobsen syndrome, if there is any type of hypogonadism or testes insufficiency producing less steroid hormone like testosterone, then perhaps that condition won't just resolve in time, and we want to really be aware of that. So if we're looking then at rates of growth, you can see that kids will typically be growing when they're very young much faster, and then they start slowing down. And then once around the time when they hit puberty, you can see that they actually start to really speed up their growth. And then this makes it a little bit more apparent how slow these kids can grow just before their growth spurt. Boys typically have their growth spurt after girls. They typically go into puberty after girls. generally by about 1 or 2 years. And this is why often we see such a size or discrepancy with the same age kids right around the time of going into puberty. Also, a point is that girls typically get their growth spurt at the very beginning of puberty. Guys tend to get it in the middle part of puberty, toward the end part of puberty. So if we're assessing someone, we wanted to see, are they on target? One of the things we really want to know is where they should be, and then that gives us an idea basically for a height prediction of where we'd expect them to be, putting everything together. So we use a mid-parental height calculation for that. There's a lot of different calculations, and you probably heard some when in the pediatrician, oh, double this and quadruple that, and typically what we end up using in our endocrine clinic, which works for the most part fairly well, is we want to keep the percentiles, and so typically for boys and girls, men and women, the average height difference between man and woman is approximately 5 inches or 13 centimeters. And so if you're looking at keeping or the percentiles the same for someone and then averaging their height, what I mean by that is if you were assessing a boy and you wanted to know how tall that boy was going to be based on their parents' height, you would take dad's height and then you would take mom's height and then add 5 inches to mom's height. Okay, so if you look at this growth chart again, you'll see that typically around the 50th percentile for a guy is right around 5'9", 5'10". For a woman, it's right around 5'4", 5'5", and so it works pretty well with that. And so then for a girl, what we would do is subtract 5 inches from dad's height, average that with mom's height. Okay, so that will give us a height prediction of plus or minus 2 inches, and all other things being equal, then that should work fairly well with it. But plus or minus 2 inches, if you really start using this and plotting a growth chart, it does take up a huge chunk of that growth chart. So you really have a lot of room up and down to work with, and so that's part of the reason why it probably works so well, is because there's such a wide range of the number right there with it. But something else we're also going to use as a height prediction is their bone age. So if we used a mid-parental height, you can see it just with boys or girls, somebody could have 42 kids, 42 boys, and we'd give them the same number for every single one. If you had somebody that knew, if you had this particular person here and you said, you know what, how tall is this person going to be, you would have their height. You would have also, if you got an x-ray of their hand, you'd be able to have an idea of how much growth they have left and give you a better height prediction for that person. And so often what we do when we do our assessment, we not only do the mid-parental height, is we end up doing, so this is just an example of that which we had just done, but we also look at a bone age. And so these bone ages, what we're looking for is these spaces between, so this is of an 8-year-old boy and this is of a 14-year-old boy. These spaces that don't show up in x-ray don't show up because it's cartilage. Those cartilage cells make more of themselves, that growth plate then expands out and then causes the bones to get longer. What causes those growth plates to get smaller or close up are the cells on either side converting that into bone, closing that growth plate up. That's estrogen dependent. So it's either going to be estrogen from the ovaries for girls or estrogen coming from testosterone from the boys. And so that's going to be, of course, increased during puberty. If you have someone that is not producing enough testosterone, you're not going to have someone that's really going to, you're going to have someone that's perhaps going to have a delayed bone age. That growth plate is going to be wider. So you can see that the growth plate for this 8-year-old is a bit wider in here than what you have for this one over in here, which is a lot more closed for this 14-year-old boy. And for boys, the growth plate typically closes around 18 years of age, and for girls, typically around 16. And that just has to do with the timing of puberty and the response to hormones on the growth plates. So if we're looking then at plotting someone, we want to keep that in mind. If someone does have a delayed bone age, meaning that their bones look younger than them, obviously they're the same age, they were born with those bones, but if they looked younger, meaning the growth plates were wider, we would say that that person has more time to grow, okay? And so this would be someone that we would describe as more of a late bloomer, but again, keeping it in context of Jacobsen syndrome, cryptorchidism can occur. And this is actually of a group of patients, and Paul was involved with this, and this collection of 9 children here in San Diego were studied. 4 out of 6 males, or approximately 67%, were identified as having cryptorchidism. Now, cryptorchidism is a potential sign of hypogonadism, okay? So cryptorchidism, undescended testes. So if the testes don't descend, that may be what causes the descent of the testes is typically hormone dependent. So if they're having a problem with making those hormones, not only may cause the testes not to descend, but then also could result even within the testes themselves of not further producing those hormones. So it not only could be the cause of the undescended testes, but the undescended testes themselves later may be a reason why there may be further decrease in these hormone levels, which then could cause a delay in puberty or perhaps later even a need for hormone replacement in this area. What we're also looking at is because of the decrease of these hormones, we often will see delayed bone ages with these people, and so that have cryptorchidism or decreased gonadal function, and so that may give us more information in terms of height prediction for that person. Later, delayed bone age, again, giving them more time to grow. When other people stop growing, they may grow for a longer period of time. There are also could be specific endocrine causes of short stature or not growing very well. The things that we typically screen for endocrine clinic is one is thyroid and the other is growth hormone deficiency. For growth hormone deficiency, decreased production of growth hormone, you don't typically grow very well. Thyroid also is very important, and actually if you're deficient in thyroid hormone, which has been identified not commonly, but with Jacobsen syndrome, and next slide here actually will identify that, which we had as a case report, will actually cause a decrease not only in thyroid hormone, but also a decrease in growth hormone. And even for any child, when we submit in for under the diagnosis of growth hormone deficiency, insurance companies want us to document what the thyroid hormone level was. If the thyroid hormone level is low, they're not going to pay for it. They're not going to buy the diagnosis. And the thing is that also too, is that if we do identify someone as having growth hormone deficiency and thyroid hormone deficiency, some children are born without a functioning pituitary gland. Without replacement with the thyroid, those boys or girls typically don't grow very well at all. And so even if we do replace one and not the other. So thyroid is very important, so we do check with that. And why I'm also really highlighting thyroid here is although it hasn't been reported as all that common, constipation has been reported as being more common with Jacobsen syndrome. Constipation is one of the things that we hear as endocrinologists as one of the most common presenting complaints for pediatricians or for us to trigger us to check for thyroid. And also too is that of course constipation could be for a number of reasons, but that's something just to keep in mind. And then also with that, it can also, one of the presenting conditions, decreased appetite. We're going to go over that today also with other things, other confounding conditions that may be misleading either us or others to believe that maybe there might be an underlying thyroid problem. But of course what we really see in both these cases is, there we go, okay, is decreased growth. And you can see in both these acquired hypothyroidism, so these are children that are not born with hypothyroid, and just hypo being low, thyroid for the thyroid hormone. You can see that their growth charts pretty much are flat across here, and they plateau out. When we start replacing with thyroid hormone, they really pick right up. With growth hormone deficiency, for the most part, we see a growth chart similar to this. Often it's not quite as profound as this. We do see children that do fall off. Something also to point out too about acquired hypothyroidism, again, we typically would see this after maybe 3 or 4 years of age. We don't usually see this in very young children. The most common cause of acquired hypothyroidism is autoimmune. So we just went through the whole lecture there with immune system. There are autoimmune conditions. Autoimmune conditions are when your antibodies will attack your own self and cause destruction of that, or at least in the very least inflammation of the gland doesn't work very well if we're talking about the thyroid gland. And so if you have an autoimmune thyroid condition, you may not be producing enough thyroid hormone. So it's actually the most common cause of acquired hypothyroidism in the general population. And if you're looking at acquired hypothyroidism, most autoimmune conditions don't generally present before the age of like 3 or 4, but we have seen those patients. Same thing with growth hormone deficiency. We often don't find this happening immediately, and that's mainly because your body doesn't necessarily rely on growth hormone per se to help growth during infancy. Usually it relies on some different growth factors, other growth hormones like IGF-2 or insulin to help with that. And it will transition out and be more dependent on growth hormone. So even our children that are identified with growth hormone deficiency, often in the first few years, they're not really that small, and then later on they do fall off, and you can see that's something that's also emphasized here on this slide. So with growth abnormalities in Jacobsen syndrome, there have been case reports suggesting an association of smaller growth or smaller stature and decreased growth velocity with patients. And there are 6 publications with 5 single case reports. And this actually, I have to double check because when I was going through my little updates over the past about 4 months now since there may actually be another one in there, so I have to verify that. It seemed to be using a lot of the same data from before, and so, but there are reports. And also in a series that we had in San Diego of 8 affected patients with Jacobsen syndrome, and then there's also a publication of central growth hormone deficiency, so growth hormone deficiency, and also thyroid hormone deficiency. And studies suggest that the genetic information encoded in the chromosome is important for normal growth. Often though, and we're just starting to understand a little bit more of what's actually causing more of the problem, because a lot of these patients, some do, have growth hormone deficiency, and some also then have what we have as features that would indicate lower growth hormone levels, but not profound or overt growth hormone deficiency. So in this group of patients that we had looked at here, 6 of these 9 patients had a stature that was more than 2 standard deviations below their peers, and that's pretty significant. To give you an idea of what that means, just standard deviations is how much farther below the mean that we have there. One of these children had intrauterine growth retardation, which we'll talk about that today, and then also 4 had low IGF-1 levels, which I'm going to explain to you what is IGF-1. With that, a lot of times in the clinic, when we start explaining these things, people are like, and then once we draw things out, which we'll take a look at here, and we'll just see what we're really talking about. So growth hormone is released from the pituitary gland in pulses. The pituitary gland releases a lot of other hormones. It's in the brain, in the middle of the brain, about the size of a pea, and releases a lot of different hormones. One hormone, growth hormone, is released in little pulses. And then that growth hormone travels in the blood. It has direct effects causing growth. It also has effects that go to the liver, causing the liver to make IGF-1, and then also another growth factor, IGF-BP3, which is more of a carrier protein for that. Also there's, in the slide here, it shows IGF-BP1, which has more of an effect more on glucose and insulin levels. But really what we're going to be looking at for this slide is IGF-1 levels, because IGF-1 can be then used as a surrogate marker for growth hormone deficiency. It's found in a steady state in the blood. You can draw it any time during the day. It doesn't have to be done as fasting or in the morning or whichever, and doesn't require a large amount of blood. I just, a few days ago, was meeting with Quest Diagnostics, the head of their laboratory, which who I'm doing research with, John Nakamoto, and we're trying to go ahead and even create smaller and smaller samples, and also using tandem mass spectroscopy in order to even generate more accurate levels of endocrine hormones and other lab studies too, using very, very small quantities of blood. To give you an idea, we can do blood samples for a whole series of steroid hormones with using about 1 or 2 drops of blood right now. Also, what we're able to do is we're able to put this on filter paper, so you're able to even do, like if you know anybody who has diabetes and the little finger pricks, they just do it. 1 or 2 drops of blood, put on a little filter paper, put it in the mail. It could be dry, and they can use that. They also then could generate more data from that later because if they needed to, say if the doctor, I don't know how many times this has happened with you guys, oh, we wanted to get this, oh, but you didn't get it. Can you go back to the lab? You know, they can also pull that on from the filter paper, which right now that's still being worked out there with them. But other labs are also doing this too, and so this is good for us, especially with our children that are requiring blood tests and screening for different conditions, and perhaps maybe helpful for immunologic screening, which, you know, that's one of my questions, but I'll ask that later to our other speaker, Dr. Perez. So if we're looking then at what are the different ways of, oh, just to mention, why do we not measure growth hormone directly? Because it's released in pulses, and you never know you're going to catch it at a high or a low. This is not a very reliable number or laboratory value unless you provoke or stimulate the pituitary gland to release growth hormone, which is a growth hormone stimulation study, which we'll see in the upcoming couple of slides. So if we see someone for their growth, and if they are falling off their growth curve or experiencing decreased growth rate, or just plotting below where we'd expect them to, what we really want to also make sure about is looking at nutrition, because undernutrition does affect IGF-1 levels. We see that very significantly, and children don't typically grow very well. We also really don't get much of a benefit from giving children, even with children with growth hormone deficiency, improved growth if they don't have enough calories in and if they're not growing very well. Also now, more recently, insurance companies have kind of clued into this, and they do request growth charts, not only the height ones, but also the weights. And more recently, we've had insurance companies stop payment on growth hormone if children are not gaining weight. And the thing is that you can look at that from saying, they're into everything, but at the same time is that it also is something that we really should be aware of. If someone is not gaining enough weight, they're really not going to be growing very well. We really need to address that. So why do we bring this up with Jacobsen syndrome? It's because we just mentioned that some children are born with intrauterine growth retardation, and if you're born at basically with underweight, less than the 10th percentile, that's could be, if it's even below that, could be considered something called small for gestational age. And if you meet the criteria for small for gestational age, then that condition is an FDA-approved indication for use of growth hormone. Those children, we do not stim for that. We don't need to bring them into the hospital, do a 6 or 8 hour infusion study, multiple blood draws for growth hormone deficiency. It has its own ICD-9 or diagnostic code and its own FDA-approved indication for growth hormone. Typically with those children, we don't get much of a problem in terms of getting payment. There are other FDA-approved indications like idiopathic short stature, which we'll go over, that we do have much more of a problem with. So basically what we're looking at to see if somebody is caught up in terms of where they should be for their growth by 2 or 3 years of age. Bringing this to light of what we're here for right here is looking specifically at Jacobsen syndrome, and it's been reported as maybe approximately about a third of birth weight below the 10th percentile. So really looking at that and seeing, do we meet this criteria? And then the other, of course, is, and it's not just a matter of meeting criteria, but are we going to get a benefit from growth hormone, or what really is the best intervention, which we'll go over, and then what, of course, really are the risks and benefits for doing all of these. The other is that some children with Jacobsen syndrome are reluctant to suck as infants or have difficulty with coordinating sucking and swallowing. There can be problems with gastroesophageal reflux or GERD. We're going to have the GI lecture after this. Following this, I imagine there's going to be some information about this. Even with careful positioning and sometimes medication, if this is not helpful, there may be G-tube placement, Nissen fundoplication. And if you're getting any of these that are impacting us perhaps nutritionally, and of course dietitians will be involved with this too and really helping out to maximize calories, and doesn't necessarily mean that if you have a G-tube or a Nissen that you're not going to gain weight or grow well, and so we like to make sure that you're getting enough nutrition. But just making sure that we have this, because there also can be, of course, behavioral emotional issues attached to this too, and we see with Jacobsen syndrome, with some children with emotional issues or behavioral issues, it can kind of confound this. And so really just making sure that we're on top of this, not only from a growth standpoint, but also for that. And then, of course, just the opposite too, is that often short stature or being smaller in stature is a stigma. It's something that often will affect people and what their how they perceive themselves or interaction with others. And there's so many studies with this. I had this in others study, they're talking, it just goes on and on and on of different things that are brought up, and there's studies looking at salaries with people smaller stature. Perhaps they're getting less in terms of salaries, promotions, and it never fails. Every time when we have an endocrine meeting, and it happened again this last week in Houston, the Endo Society, somebody brought this up, and then you always get one of the endocrinologists that are out there, and they grab the microphone, they stand out there, and they say, it's usually a guy, and he'll say, I'm 5'3", I have a beautiful wife, and I make a lot more than our chief of our division. I rest my case, and he sits down. So, so it just, it just, there's always, variances with that. But it's something to keep in mind of what we really want the best for our children. So gastrointestinal tract malformations has been reported as many as 18%. And some of this information, we're getting more information from these, and we perhaps may have some newer information even today with that, but this is from what we are having dated back from 2009. I realize it's 2012, but we're trying to acquire more information. Something I did want to make note of is pyloric stenosis, which has been identified in children with Jacobsen syndrome. That can be associated with nausea, vomiting, and also with poor intake. So that may also then could result in someone being nutritionally deprived if it really isn't addressed. But then there's also too, what I was looking at is if there was any implications on growth with this, if somebody was actually to take growth hormone, because this is a growth, and every time we look at any type of abnormal growth, such as with a tumor, we want to make sure then are we making anything worse. Pyloric stenosis has been identified with having increased IGF-1 production and effects right there at that area, but it doesn't necessarily seem to, we don't really have the information on that, but it doesn't really seem to be worsened by growth hormone, but that's still kind of out there, it's open. The other is something that we get referred to regarding growth quite a bit, is with children that have ADD or ADHD, and if they're not growing very well. And there have been several publications identify as poor growth in children with ADD or ADHD. A lot of them point toward nutrition. And one study that I was involved with when I was at Yale before I came over to UCSD is we were looking then at this and specifically trying to address is there more of a direct effect from the medication. Although always when you bring things up, is statistically significant, it came very close, and there have been other studies that have demonstrated that it suggests that some of these medications perhaps may have a direct effect, although we don't have the data to substantiate that, to say that it does. But the thing is that more of what we're seeing is decreased appetite, decreased weight gain, then subsequently, just as we were describing with nutrition, poor growth. So I'm not saying up here that methylphenidate or some of these medications are actually decreasing the growth directly, although we just don't have the data to say that it does or doesn't necessarily affect that. Something that we are still looking at. In any of these different studies or information, if you guys had questions about that, I can always give these to you. And a lot of times I know that these are different studies that are written for other medical professionals. But if you have someone that's going to be able to kind of walk you through them, so almost like a little journal club, individually with you, then sometimes that's nice, and I've done that with patients, and I can do that with you guys if you had specific questions about what you're reading in the literature. As people are getting a little bit more, involved with getting information online, how reliable is that information, and what does this really mean, and how does it apply for my child, so these are things that we have been looking at, and the reason why is because specifically with ADD or ADHD is some with Jacobsen syndrome have been described as having behavioral problems, most commonly attention deficit or hyperactivity disorder. So if you're having someone that's going to be prescribed medication, they're having decreased appetite, decreased weight gain, then maybe we got to really look at that in terms of if that's really what's affecting us in growth, just to kind of keeping things in perspective. And then as Dr. Grossfeld-Paul is going to be talking to you guys about, speaking about a lot of cardiac associations with Jacobsen syndrome, that's something that we really do look at carefully with any of our kids with growth. Just as we're considering nutritional input or intake, we're also our caloric intake, we're also looking at expenditure, and some of the kids that end up having cardiac defects end up having inefficiency with their caloric expenditure, meaning that they're maybe spending a lot more energy just with the circulation than perhaps other kids, and so maybe that might be part of the reason why they're not necessarily growing very well. You also have any condition that's more of a chronic condition can cause chronic effects and on the body, and some of those might be steroid mediated, some not, but any chronic illness could perhaps also be related to poor growth. The other is then looking again, just like with pyloric stenosis, does growth hormone have an adverse effect on anything that we've done? So if somebody had a VSD, a ventral septal defect, septal defect, and they had that repaired, and we're like, okay, we're doing okay, and then suddenly they go see an endocrinologist or on growth hormone, is that going to make things worse? So there's a lot of data that we're still accruing on that. We have information on some more common conditions, Turner syndrome, Noonan syndrome, and fortunately in a lot of these conditions it doesn't seem to make necessarily things worse, and in some ways perhaps might make things a little bit better in terms of the functionality of the ventricles, and perhaps aiding in the recovery from surgical procedures or in strengthening musculature. And so we're still looking at that, but it's still very open in terms of, or uncertain in terms of what we're really looking at specifically with Jacobsen syndrome or these conditions, with that. And that would defer with Dr. Grossfeld, but the thing is that realize that, if the specific condition, you can also speak with that with your endocrinologist local, and that's something that, whether or not, if all of us are going to be going to see an endocrinologist, I would recommend, then we'll go over this at the end, then is more of when we had recommendations. If someone was not necessarily plotting or growing as to what would be expected for the family, this may be someone to send to an endocrinologist. The other is that cryptorchidism may actually be another reason too. Now with growth hormone deficiency, and we do get a lot of questions with this, like who qualifies, does this help or not? We do initially measure IGF-1, IGF-BP3 levels as surrogate markers to determine, to give us a height or growth or prediction to see if somebody is actually growth hormone deficient. Then we'll actually do growth hormone stimulation testing. This is what we need to demonstrate to the insurance company that someone is growth hormone deficient. And we do stimulatory or stimulation to the pituitary gland, measuring then serially growth hormone and multiple draws. We usually place in an IV for them to go ahead and just draw from, so we don't have to keep sticking the person. But it takes a good bulk of the day there. There are then not only hormone deficiency, but other conditions that we do that are FDA approved for growth hormone. And really for us here for Jacobsen syndrome, we're really going to be looking at growth hormone deficiency. We have identified this in some individuals with Jacobsen syndrome. Other would be, we mentioned small for gestational age, or IUGR. that also is an FDA-approved indication for growth hormone deficiency. And another one I highlighted here, which is ISS, or idiopathic short stature. And this is more of a, not a true diagnosis, but more of if we have someone that just is not predicting to be where we'd expect them to be for the family, growing at a growth velocity less than 25%, and having a height more than 2.25. Here is listed as 2.5, more recently 2.25 standard deviations below their peers. And so because of that, if they do meet that criteria, then although this is an FDA-approved indication for growth hormone, unfortunately many of the insurance companies are not paying for this, but this is to be more of a struggle with them. Something to keep in mind is that with any of these conditions, is growth hormone safe? Is growth hormone effective? We do see that children with growth hormone deficiency, SGA or ISS, do grow and tend to grow very well with the addition of growth hormone. On the flip side of that, if you're not growth hormone deficient, if you don't meet the criteria for SGA or ISS, you probably won't benefit from additional growth hormone. It's nice that we have that information now. This is fairly new information from around 2002, which I know is about 10 years ago. But what we used to say before, and if people said, you know, would my kid benefit from growth hormone? And we used to say, well, there's a 50-50 chance that they may gain an inch or two. And if you think about that answer, it's not really much of an answer, is it? You know. Next question is, well, then, you know, which group is my kid in? You know, well, we don't really know that. Now we have a little bit more information because of where they're plotting and their growth velocity to help with that. And then also, too, is that, again, are we doing any harm? There's been different reports out there more recently in the Lancet, and that was looking at tumor risk for individuals that got growth hormone. It was more of a follow-up study, retrospective study looking at adult males that got growth hormone when they were adolescents. The doses with that were a little bit uncertain. They were also using cadaveric growth hormone. These were adult males in their 40s assessed for conditions like colon cancer that were, or prostate cancer, looking at growth hormone that was given in doses that weren't necessarily documented. So that wasn't quite as helpful, and although the information was a little bit increased, it was statistically significant. But a lot of us, after when that came out, that raised a lot of red flags, and since that time, we really haven't seen that. And since synthetic growth hormone has been out since 1985, we're getting a lot more data on that, and it doesn't seem to cause those tumors that we're seeing. But right now, we're right around the age of when, or the time when we should be seeing those individuals with that. There are databases out there for the different growth hormone companies. A lot of the companies now are starting to close those databases, but we have a lot of information out there that we're still getting and entering data into for the ones that do exist. For the majority of the growth hormone companies, in the past at least, every kid would be entered, so we did get a lot of information from that. With secondary tumors, if somebody did have one malignancy or tumor neoplasm, then they do have an increased chance of having a different neoplasm. One of the joint or comprehensive clinics that I'm also I participate in. I'm the endocrinologist for our UCSD Rady Children's Neuro-Oncology Endocrine Comprehensive Clinic. So it's the children with brain tumors then come in with that. Why we specifically looking more brain tumors is because of association with the pituitary gland. But with any tumor, you can actually have an increased chance. So because there may be increased chance of malignancies with Jacobsen syndrome, it may be something we might want to consider carefully there with that. And then the other is there was an incidence or a report of increased leukemia in the past, and this doesn't really seem to hold up. The studies were actually done or reported in Japan, and so when they first did that, they were reporting increased chance of leukemia, and they were basing it on what they felt it should be, but then they looked at the prevalence of leukemia in their population, and where they studied these patients was within Hiroshima, and they found out it was much higher. And actually, ironically enough, the kids that were on growth hormone, the leukemia incidence was actually less, or prevalence was less. So you're never going to get anybody saying that growth hormone is protective against leukemia, but it certainly didn't see causally related. But as we're getting a little bit more information with that, and we do seem to get more information. If you ever, somebody, I didn't put this reference down there, but he does a lot of these studies. It's Charles Sklar, S-K-L-A-R, Chuck Sklar in New York, and he's a real good guy. His information or data is really good there, and so you can always get a little more information of where we're at with that. And then the other is, you know, when we're ever evaluating any of these patients, we're going to be seeing and tracking them and following how well they're responding. We do check IGF-1 levels periodically, and that tends to be a fairly good marker of whether we're doing things in a safe way. And of course, with all our kids, and we love them, we want them to thrive and to get as much as we can out of every opportunity, and but we want to do it, of course, in a safe way. So making sure that you're linked in, and I would say with this, probably, although not every place has a pediatric endocrine division, it probably would making the effort to really be in with someone that also is very familiar with pediatric endocrinology, if they are an adult endocrinologist in your local area. And of course, you can always consult or ask us, you know, too, and send information over, and we'd be happy to help you guys out with that, keeping everything in patient protection information, of course. So in summary today, really, is this Jacobsen syndrome has been associated with endocrine disorders, and the features of Jacobsen syndrome could be, or should really be considered with identifying those conditions. Looking, again, constipation. Is this constipation, is this more of a GI issue? Is this hypothyroidism? Is this the reason why perhaps we may not be growing very well? Nutrition, are we having issues that we need to work on with more of nutrition? Or that person not gaining weight because they're growth hormone deficient and they're not growing very well? And then, of course, looking at the treatment really directed more on this balancing the risks and benefits, you know, with our children. So with that, just wanted to open things up for questions if you guys had any questions. Oh, yeah, sorry.
Okay, great.
Ready about that?
I think we have time. I think we have time for about 5 minutes of questions, and then if Dr. Kelly is willing to hang around, just in the interest of moving the schedule along. We'll go down here, there. So 4 questions, okay?
My grandson has been on a program regimen for a year now. And he was born on month 30, he weighed 7 pounds. He's a big, healthy boy. Hasn't had a lot of illnesses or anything, but about a couple of things, like all these things you were mentioning. He had an undescended testicle. They thought, they went in and said, oh, wasn't born without one. A year ago, it ruptured. Took him a week to find out. He was in the hospital. All this, you know, and he took ADHD medication for a few years, but we just stopped it. Didn't seem things getting better, getting worse. And he was growing fine till about, I noticed a couple of years ago that, you know, he's in choir, and all of a sudden he's like way shorter than everybody. So we took him to an endocrinologist, and he's not producing the growth hormone. So in the last year, he's gone from about 5'3" to 5'6½". And the only thing, as far as benefits, I mean, it's like he's 16. He's more mature. I mean, his whole body has just changed. He's more lean muscle. He's more, his hair it used to be kind of dry. It's gotten curly, darker. Just his overall appearance is just a lot healthier. And the only thing, and we've asked, and they keep saying no, and they keep giving it to him. And I did notice that before we started taking this, he has Sherman's disease, kyphosis, not scoliosis. It's where you bend this way. And they keep saying, and I agree, because I noticed it, and I went to his pediatrician. Oh, he has bad posture. A year before, this is like 2 years ago. And then we went and we started him on it, and it doesn't seem to have gotten any worse or anything. And they say that it's okay to keep taking it while he has this, because it should, you know. So that's the only thing. I just want to make sure that that is not going to get worse, or because they said no, it's a childhood thing. I guess it would have happened anyway, and just kind of have to deal with both of them, but he seems to have done really well so far.
Yeah, the scoliosis kyphosis, just a variant, or sorry, it's a form of curvature of the spine this way. It's just this way instead of like an S curve. Typically shouldn't get worse with growth hormone because growth hormone does act pretty much in every cell of the body, and so it really should be equally affecting the growth, and so you're not going to get one side growing more than another. You'll see with some patients, though, that if they do get referred in for other conditions, and we fear that they may have something we call a skeletal dysplasia. This is a condition with the bones that perhaps may not be growing appropriately, or I hate using that word normally, but some part may grow a little more rapidly than other parts. If you have that part that grows more rapidly or being more responsive to growth hormone could cause exacerbation of the curvature. But typically the growth hormone itself really shouldn't really be doing that. Although I will say, though, that I've had some patients and others have had patients that it does seem that the curvature may get a little bit worse if they're growing rapidly and they have perhaps bad posture during that time. And so if they are really growing rapidly and they continue to have bad posture, it may exacerbate that because of the direction that their bones are growing, I guess, if you put it that way.
He wears a brace, and they're kind of, you know, 4 months on, 4 months off, take pictures to see if it gets worse.
Right.
It's a crazy brace up around your neck.
Yeah, yeah.
And we're constantly telling him, stand up straight. And he can. It's just that he'll lose it. But he's actually gotten better about holding himself up. And he's a big boy. He weighs like 170. And he's very muscular. But they want him to lose weight and get a fitness trainer and train and strengthen the core muscles and his back.
And yeah, and growth hormone also does decrease fat mass, it does increase lean body mass, muscle mass, it does increase bone density and also the strength of the bones. And the muscle mass itself, it's actually for growth hormone replacement with adults, it's really the only thing that we've really been able to document is increase in bone mineral density later. So it does, that may actually help out with that, perhaps maybe strengthening the back to place us in with better posture.
That's what they said. They said if you constantly fuss at him, but if you give him the tools to keep himself up, the stronger stomach muscles, those better back muscles, that should help.
Yeah, and often sometimes what we'll do is we'll do physical therapy with that to help, depending, you know, what each requirements are for each one. Okay. Somebody had,
Just a simple question. Is there data about growth hormone being used on any Jacobsen's kids? And what was the result? Did it help? Did it work? Were there side effects? Is there anything like that? Forgive me if you already said this.
Yeah, no, for some that had been identified as having growth hormone deficiency, and those individuals that did receive growth hormone, from the reports that I have, they did grow well with that. So it wasn't that they did not respond to it, but it's just, it's not a large number, and so we're still getting more information on that.
But there was some sign that it helped. One other little side question. Our son is following a growth curve that sort of looks like a growth curve and it's normal. He's just very small for his age. He's kind of like below the chart, but on a growth curve. I'm expressing that comprehensively. But would you recommend growth hormone in that circumstance where there is an arc and a track that's happening, but it's just sort of below, you know, off the charts?
What you would really want to do is just identify what was happening there. You know, what was the cause for that? So perhaps it could be that they're not gaining weight at the time. You know, we'd have to really look at that. There also could be, I mean, what if there was a thyroid issue? So it may not be a growth hormone issue. It might be that they have a delayed bone age, and it may just be that they have the time to grow. But you just want to make sure, of course, that they are growing during that time. So we do assessments with growth velocity where we'll look over about a 4 or 6 month time period in between, and that's mainly because we really want to get a good idea. You know, we all have those kids that just, they'll grow real fast and then they'll stop growing for, you know, weeks, and then they pick up again, you know, with it. So so little spurts of, like, little growth spurts. So with that, so we really want to look over time. But if you are falling for the growth, you really want to make sure that what's happening with that. So that would be a red flag to really investigate. Yeah. Oh.
Hi. Are there clinical reasons to worry about her being smaller than average? Meaning, I mean, a lot of the recommendations that we're getting are, well, she's going to be really small relative to her peers, so there's implications for her from an interaction standpoint. They might not treat her. If, you know, setting that aside, are there reasons to give her growth hormone, or do you know what I mean? Like,
yeah, so there's this, right, so there's the psychosocial aspects of things. Then there's the occupational side of things, and perhaps, you know, it might be a little more difficult to put something up in a top shelf of something. Driving a car, the distance, safe distance, you know, between the steering wheel and yourself. Airbags are specifically designed for certain size people. Then also, though, on the other side, if you are growth hormone deficient, then that can lead or be associated with decreased bone mineral density, increased risk of fractures. It also could be associated with extra fat tissue and lean body mass is decreased, muscle mass is decreased. That perhaps has an implication with the blood sugar levels. Also, growth hormone has been implicated in organ healing, tissue healing, and also been associated with the immune system. So we had that talk earlier this morning, and so it does seem to have some benefits with that, but there's a lot of data still being generated in that area. So there may be other medical reasons other than just stature. So that's why when somebody is identified as having growth hormone deficiency, I would say that you're really going to probably hear from an endocrinologist, let's move along this pathway, more so than if you're, not just because of stature growth, but because of the other issues with that. They're trying to identify to see if these are persisting and with adults. If you had somebody that was growth hormone deficient as a child, about 70 to 80% typically are not growth hormone deficient as an adult. I'm giving you data based on more general population, not something specific for Jacobsen syndrome, but those individuals that are growth hormone deficient, what are the benefits for that? And the only thing we've really been able to demonstrate in the studies, and you can imagine the growth hormone companies are less funding these because it's suddenly now they lost all their patients after they're 18. For the next 80 years, they probably want to go ahead and keep the money going. So is bone density. But we're also looking at other, and there's also some subjective reasons, if you want to call it that. Sometimes with people, if they were on growth hormone before, they come off and they say, you know what, I just felt a little bit better. So sometimes what people just have that, how much you want to categorize that. But in terms of other medical reasons, that would be them.
We have time for 2 quick questions.
Okay.
And then just because Dr. Tipples has to be back.
Yeah. Okay. Sorry. Okay.
No, that's fine.
Okay.
I was actually really interested in the muscular effects of growth hormone and how it goes through IGF-1. So I was wondering if there are any studies in developmentally delayed children in general where, because it increases muscle mass, does it cause them to have better gross motor, hit gross motor milestones sooner than if they hadn't received it?
Where you're going to see a lot of that information is for the use of growth hormone with Prader-Willi. And so with Prader-Willi, we have hypotonia, decreased muscle tone, and those kids could be significantly delayed in achieving or attaining their milestones. We do see use of growth hormone for that condition alone, just for increasing the muscle tone, overall muscle mass, and achieving milestones, being able to sit up. And we've also seen associations with perhaps improvement of a condition called tracheomalacia, which some of those kids do suffer from. That may actually improve that. So maybe perhaps some kids coming off of oxygen support. So there is some with that, so increasing strength of the muscles to help them achieve or attain milestones.
Are there specific studies that we can look at or citations that you have?
Yeah, all I would say is just look at, for that one, just do Prader-Willi, growth hormone. Because we also see Prader-Willi later, and some kids are growth hormone deficient, and that will help out with their stature. But the thing is that for little kids, babies, we're going to have those. And a lot of times the insurance companies still aren't on board with that. A lot of times they like to see that we're growth hormone deficient as well, but with that is an FDA approved indication, and as part of the indication is for infants, for use of hypotonia. So we have documented that, and we have got approval for that reason and seen positive effects. So just Google Prader-Willi growth hormone infancy and you'll probably be set. Okay.
Was there, no?
One
all right,
more?
I think we should, all right, one quick question. as we're setting up anyway.
Open a can of worms.
Well, we'll close it later.
Our daughter Elise, who's 2.5 years old, she has high estrogen levels and high LH levels.
Right.
Her IGF-1, I believe, has fluctuated in the past. She just recently went from 25% or better on her growth indicators to 10%. And it seems that every time her growth hormone drops, she starts to develop breast tissue on one side. Is there anything you can think of?
So growth hormone itself won't, and even when we give people growth hormone replacement, or growth hormone itself is not, it does not trigger on puberty or increase estrogen, which would be the cause of breast tissue. There is, on the opposite side, that estrogen increases growth hormone production and release, and that's why you end up getting a growth spurt during the times of puberty. But if we're looking at what you're describing, you're saying if the growth hormone level decreases, this is measured by IGF-1 then, if you end up having true breast tissue, and if you have someone in that age group, then that really is going to be a workup that you really want to make sure, is that person in puberty or not? And they could very well just have breast tissue, isolated breast tissue we call benign premature thelarchy, and it may not necessarily even be associated with laboratory values. But when you do see laboratory values that are elevated, and you mentioned estradiol being elevated, and the LH level being elevated. LH is a gonadotropin. It's a hormone that's associated with stimulation to the ovary. That, as well as FSH, are associated with puberty. So if you have someone at 2.5 years of age with an increased increased estrogen level and breast tissue, you really want to make sure you see an endocrinologist. Okay, because it could very well be benign, but it could also be early puberty, and we very well could have a treatment for that, depending what it is. So, not the big of a can of worms. I'll be around for a while if you guys have questions. Okay, thank you again so much. Okay.
And I particularly want to thank Tom for giving his contact information, which most physicians are absolutely resistant to doing. So take advantage of that. So it's probably